Greetings from Bilmed. Myself, Dr. A.B. Wani, Director of Bilmed Group of Institutions. With me today is Professor Dr. Gunjan Goel, and we'll be taking today a small session. It is not like a class, but it will be like a interactive session, a panel discussion type, and the topic is ovarian pathologies. Now, what all we are seeing in these ovaries, I mean, what type of pathologies we are seeing in these ovaries? Mostly cysts. Right now. Now, from these cysts, in your day-to-day ultrasound scanning, or you are a gynecologist, you are seeing the patients, what types of cysts we can expect in this ovary? First, simple cyst. What next there can be?
Functional cyst, there can be.
Functional cyst, there can be. So this all is in the simple cyst, right? Now there can be a hemorrhagic cyst also.
Obviously, there can
right?
be.
Can't there be an corpus luteal cyst?
Of course, there can be.
Dermoid.
Dermoid cyst.
Dermoid cyst. Then sometimes we have to differentiate a dermoid from an endometrioma. Now endometrial cyst can be there, chocolate cyst. Can't there be a PCODs in that ovary? A PCODs can be over there. Is it not possible that you have hyperstimulated the ovary, and due to the hyperstimulation you are seeing multiple cysts? So lastly, there can be a complex cyst in the ovary, and this complex cyst will, make shake whole of your neurons. Maybe this complex cyst is a benign or a malignant. So this all can be seen in the ovary. I mean, when we are talking of this ovarian cyst. Now let's talk about the first one, and that is the simple cyst. Simple cyst. What is the definition of the simple cyst? When you can label any cyst as a simple cyst.
As a simple cyst. See, actually, when it is clear and anechoic, and it is less than 5 centimeter in diameter.
So size matters. Size matters over here. Then what next? Maybe that there is some internal lobulations, septations, or a solid mass over there that is not going in favor of a simple cyst. So simple has to be anechoic, jet black, posterior enhancement.
Posterior enhancement.
And the size. So these are the criteria of any cyst to label as a simple cyst anywhere in body. I want to make a red note of that we are right now not taking a class. This is not a class but a panel discussion type. So first is the simple cyst. So simple has to meet a criteria. You cannot label each and every cyst for a simple cyst. That is the point. Now the posterior enhancement. This is the posterior enhancement. Those who are doing ultrasound or have some experience from their Gyne or whatever they have done the post-graduation are well aware of the posterior enhancement, that the posterior enhancement is the bright strip type behind the cyst. Actually, this posterior enhancement is telling me that the above lesion, that the above cyst is a simple cyst.
Yes.
So this is the posterior enhancement, anechoic posterior enhancements, and the size. Now, a hemorrhagic cyst. What do you think? What there can be in a hemorrhagic cyst on putting a color Doppler?
Actually, hemorrhagic ovarian cyst does not take colors because it contains clots.
Yeah, very good. Now, many of the doctors who are doing ultrasound but don't have a good understanding of ultrasound will put a color Doppler. Why I'm discussing this point is that they will put a color Doppler thinking that this will take color because this is hemorrhagic and the hemorrhage is having in the cyst and we are having some blood, so they are thinking that on putting a color it will take color. No, Big no, because this is not a live blood over there, but a dead blood clot over there, and your color Doppler is not picking a dead blood, but it is picking the flow in the vessels, I mean the live blood over there. Don't expect the hemorrhagic cyst to take color, and if it takes color, then
then it is not hemorrhagic
then
cyst.
it is not hemorrhagic at all. But what that can be?
That could be any functional cyst or complex cyst.
Complex cyst, then that is a complex cyst, and from complex it is going in favor of malignancy now.
Malignancy.
So if your so-called hemorrhagic cyst in inverted commas, I'm putting in inverted commas, is taking color, that can be a malignant case actually. This is the importance of, knowing the things. This is the importance of theory behind the ultrasound. Ultrasound is not all about holding the probe and doing scans haphazardly here and there. You should have a good fundamental knowledge, basic knowledge, the theoretical knowledge, then only you can do a good ultrasound. So back to the hemorrhagic cyst. Hemorrhagic cyst, they are not taking the color. Now see, this is the hemorrhagic cyst over here. This hemorrhagic cyst will never take the color. Now this color is not from the cyst, but from the adjacent, tissues over there. But if this hemorrhagic cyst from this clot over here will take color, that is not a hemorrhagic cyst, but a complex cyst and going in favor of malignancy. So this all is the theory behind all these things which we are taking in our courses, and right now we are taking a panel discussion of this ovarian cyst. Now again, demonstrating the hemorrhagic cyst. This is the hemorrhagic cyst over here, and this is the clot inside. Try to understand, this is the clot, and this clot, now see, this clot will not take color. And if this clot will take color over here, then that is not a hemorrhagic but a complex. I am going in favor of the malignancy. Right. So again, demonstrating the hemorrhagic ovarian cyst. Sometimes, now try to understand, sometimes the hemorrhagic ovarian cyst will have a solid looking structure type look over here. Now you can confuse this with
corpus luteum hematoma.
Corpus luteum 1. Second?
Complex solid mass.
Solid mass, and the solid masses are?
So, malignant ovarian.
Why not a dermoid?
Dermoid, yeah.
Why not a dermoid? So here is the role of your, knowledge. This hemorrhagic cyst will not always look like a hemorrhagic cyst like this, but sometimes if the clot is very old
and
this cyst is completely filled with the clot, then it will look like a solid thing, and you can confuse this with a dermoid or any complex cyst over there. Now on putting a color Doppler again, now see, on putting a color Doppler, if this is hemorrhagic cyst, this will not take color. If this is dermoid, again this will not take color. But if this is an endometrioma, this can take color.
Yeah, it can take color.
If it is a malignant cyst,
it can take color.
It can take color. So this way you have to play with your neurons, right? Corpus luteal cyst. Now corpus luteal cyst, in this corpus luteal cyst, if I am having a corpus luteal cyst over here, will it be anechoic?
No, it will not.
No. So it is not anechoic always. It is not anechoic. Is it, solid? Is it solid?
It may be.
It may be. Why this cannot be anechoic?
Because it contains blood, organized blood clots.
Sometimes this can be anechoic as well. So this can be anechoic.
Okay.
Anechoic. This can be a solid looking thing like solid. So the point here is that the echogenicity of this cyst varies from a simple looking like cyst to a dermoid.
Okay.
How you can differentiate it?
Actually color Doppler is the basic thing?
No. I will not say color Doppler is the basic thing. If I am a poor doctor, I don't have a color Doppler. Will I not be able to diagnose, differentiate rather this from that?
In dermoid cyst, there will be more echogenic structures seen.
Think more. This corpus luteal cyst.
History?
No, yeah, history. But before history, what days you are in?
Okay, yes.
The basic thing, what days you are in. If you are a day 4th,
luteal phase.
if you are a day 4, day 5th, then this cannot be a dermoid cyst. Now, that is the point. You have to play with your neurons. Machine will not work for you. You have to make your machine work for you.
Okay.
This is the point. So, this way you can make out whether you are dealing with a dermoid or a simple cyst, or maybe you are dealing with the Loof syndrome over there. Maybe that there is an endometrioma. Okay. These all have to differentiate with this dermoid. With this corpus luteal, because corpus luteal cyst echogenicity varies from jet black to
solid appearance.
To a solid appearance like. So, on putting a color, this will not take color, this will show you the ring of fire pattern. This is very typical for the corpus luteal. Now I am not so poor that I don't have a color Doppler. Now I will make use of the color Doppler. I should know when to use the color Doppler. Now I will put a color Doppler, and on putting a color Doppler like over here, I will see many vessels around this cystic structure, and this is called as the ring of fire pattern. Now these things are very important because sometimes there is a gestational sac, ectopic.
And most of the time in your classes, what I have learned is mainly corpus luteum cyst will be in the same site as the ectopic.
Right. So the point here is that we have to sometimes differentiate this corpus luteum from an ectopic pregnancy, and if that ectopic pregnancy is, ovarian ectopic, then this cyst, this corpus luteal cyst, and the ectopic sac will look same in the ovary, a cystic lesion. So this is the point over here. For that,
basic difference will be decidual reaction.
Basic difference we will talk, now we are going to a different topic over there. Then we will not have time. We are having only 30 minutes for this podcast over here.
Okay.
So the basic important point is that I will have a ring of fire pattern if this is a corpus luteum. Now see the ring of fire pattern.
Very beautifully shown, the ring of fire pattern.
Ring of fire. Now there a lot of physics is behind over here. Why I am not seeing more on the top? I mean this color over here, and color is missing over here.
Positions.
This is the angle of insonation, the throwing angle, which we are teaching in our classes. As already said that we are right now not taking a class. This is a interactive session, a panel discussion type. If you want more of our theory, you can join our classes, our server-based classes. So the top and the bottom will not show more of color because of the color angle of insonation. Now dermoid. Now in dermoid, now see this ovarian cyst itself on our server is approx 15 to 20 days course for this ovarian cysts only. So we are not taking, we cannot take whole of the course over here. A very basic important thing in dermoid, what we are seeing in dermoid, there is a tip of iceberg. Now see, tip of iceberg side. Let us discuss this tip of iceberg side. What actually this tip of iceberg side is?
Tip of iceberg sign is sometimes the material which is seen is just small only. And underneath there is more echogenic material which causes posterior attenuation of ultrasound rays.
Now those who have not undergone any ultrasound training will not understand you. Okay. I bet with you, will not understand you. Now the point here is that this is the iceberg, and this is the tip of this iceberg over here. Now see, this is the tip of this iceberg. What I am seeing this tip only of dermoid. Why I am not able to see whole of the dermoid? Because when beam is hitting, it is bouncing back from this tip and leaving whole of the 90%, not whole, the 90% non-scanned. Now see over here on ultrasound. I am seeing this thing over here.
So only a small echogenic thing will be seen.
Right. Now I will measure from here to here, and it comes to be maybe at 12 centimeters or at 12. Let's take 12.
It's a vague figure.
Vague figure, 12. Okay. Is this dermoid actually 12 centimeters?
No, not at all. Because so much of echogenic material is down out there.
Have you not seen any case where it was reported multiple times that the dermoid there is a cystic lesion, quiridermoid, measuring 12 centimeters or 20 millimeters, anything. But actually, when you operated, it was not 12. It was 112. These things happen. So it means that the actual dermoid is over here. Try to understand. This is the dermoid. Beam is hitting onto the tip only, bouncing back. And this all is actually the dermoid, which is not scanned due to the bouncing back of the beam from here. What to do now? What to do to get an idea of whole of the dermoid? What to do? Scan from different angles.
Scan from different angles.
Now, if you are putting probe over here and from here it is 12. You scan from here, it will now be more of 12 or maybe a less of 12. It will be 18. You tilt it more. You will see that this tip-like structure is elongating. Actually, this is not elongating. You are throwing beam from sides now and taking a maximum length. Take a maximum length. Then multiply. You will see that from one point it will be maybe a 29. Then you have to multiply this and this 12 into 29. That is the actual approx. I will say not actual, but the approx measurement of this dermoid. So this is in brief a tip of iceberg side.
Exactly.
But if you see dermoid, now see, if you see dermoid like this, here I don't have more of the solid material, and you can measure this dermoid from here to here and from here to here very easily. The problem is when the dermoids are very solid, then we will be having a tip of iceberg side. When they are semi-solid, then there is no point of having this tip of iceberg side, and this way it is easy to measure. So I hope that this tip of iceberg side is clear. Now sometimes in this dermoid I will be having sometimes hair, sometimes some sebaceous glands, sometimes some thyroid, sometimes some nail, sometimes some tooth over there, and this is the typical appearance of a dermoid. Next is the endometrioma. Now, endometriomas have to differentiate from the dermoid. Because not always dermoids will be solid. Sometimes it will be like an endometrioma also. Then you have to differentiate this dermoid from an endometrioma. Now how can we differentiate it?
First basic point is history.
History. Okay, what history is telling me?
She may be having history of dyspareunia or any chronic dysmenorrhea.
Now tell me about pain first. Now I will not be able to draw all these things. For that we are having books and the courses are there. In endometrioma, what about the pain? Will it be persistent?
Yeah, it will be persistent.
Persistent or cyclic?
It will be mostly cyclic.
Cyclic.
It may be persistent.
Will it be cyclic over here in dermoid?
No.
No. So it will be dull and persistent over here.
Dull and persistent.
Dull and persistent. Over here it will be more of cyclical. Now, if I am dealing with an endometrioma, are there not possibilities that I will be having some patches of this ectopic implanted endometrium in the myometrium also? And that will be adenomyosis. Now, if I am differentiating a dermoid from an endometrioma plus 2, if I am seeing multiple patches in endometrium, what it is going in favor of?
Adenomyosis.
Adenomyosis, that is the endometrioma over here. Now, dermoids are bilateral, more of, or endometriomas you will expect more of bilateral.
More endometrioma, more of
endometrioma, because there is possibility that one patch is in right ovary and another patch is in, so not always, but if it is bilateral, then the things are going in favor of endometrioma, and if it is on one side only, then it is going in favor. I am using word going in favor of. Now, putting a color Doppler, your favorite, each and every gynecologist loves this color Doppler. They are thinking that I am having a magic stick over there.
Yeah.
But actually this is not a magic stick. If you don't have a knowledge of the color Doppler, it will backfire. Now, in endometrioma, when you are putting a color box, will it take color? Yes or no?
Yes.
Possibilities? Yes. But dermoids? No.
No, because
dermoids
it's calcified.
Are avascular. So this way you can differentiate this dermoid from an endometrioma. So this was a brief of a differentiation. On our server we are having more than 2 classes on the differentiation only.
Okay.
Now this is the one presentation of this endometrioma
with a ground glass appearance.
Ground glass appearance. So this is another way how it can be presented, ground glass appearance. This is the endometrioma over here. Again, endometrioma. So we have discussed the differential diagnosis of this dermoid from an endometrioma. Now let's talk about the complex ovarian cyst. Whenever you see a cystic structure, and this cystic structure is not a simple cyst, is not a a hemorrhagic cyst. This is not a dermoid. This is not a endometrioma, because we have very briefly discussed about this. Then the possibilities of complex ovarian cysts are there. Now, what are the criteria of this complex ovarian cyst?
Okay.
We are having some lobulations in this. Sometimes I am having a solid mass over here. Okay. So these types of cysts we are labeling as a complex ovarian cyst. Now the point is, in this complex ovarian cyst, I can have a benign or a malignant. Now, when to label a benign, when to label a malignant, this is the point. Because if you miss a malignancy and you label that for a benign, and patient is going with a benign report and it turned to be malignant, management changes, but patient will come to you with bundle of things. But if you label a benign for a malignancy, patient is coming to you, normal patient. What I mean by normal patient, without malignancy, and he is leaving your cabin with a malignancy, and it turned to be a benign. Then you know what the consequences will be. So our basic aim is not to overdiagnose a malignancy and not to label each and every cyst for a benign. This is the point. Now this is the cyst over here. In this cyst we are having some septations over here, we are having a solid mass over here, and on putting a color we are having some vasculature over there. This we call a complex cyst.
Ovarian cyst.
Now we are giving you these rules.
So guys, this is very, very important.
This is very important for each and every gynecologist. If you are not doing ultrasound yourself, but reports are coming to you, patient will tell you, madam, where do I stand today? You should have a clear understanding of this versus that. And please go to any institute, take a good course over there, then you can decode what a radiologist has reported over there. Now first thing, in malignancy, there are some rules. The rule number 1, it will be irregular
solid tumor. Irregularity.
Irregular. Second, ascites. Third,
4 papillary. At least 4
at least 4 papillary structures. Then the largest diameter of the tumor more than 10 centimeters, and 100 is written over is millimeters. Then your favorite color Doppler. We will be having a strong
very strong blood flow in the septations and all.
So these are the 5 points which are going in favor of malignancy.
And they have been shown here also.
They are shown here. Now in benign, it will be first unilocular. Second, I will be having a solid component, but this solid component is less than 7 millimeters. Thirdly, I will be having some acoustic shadowing over here. If there is acoustic shadowing, it means that there is some calcification over it, over the top, from which I am having acoustic, and wherever calcified foci is over there is going in favor of benign. Now, the tumor overall diameter is less than 10 centimeters, and your favorite color Doppler is not showing you any blood flow.
No blood flow.
Now this way you can make out, now see, try to understand, you can make out whether you are dealing with a malignant case or you are dealing with a benign case. Now one thing is not giving me a clear-cut diagnosis. For example, if there is a strong blood flow and there are presences of acoustic shadowing and the largest diameter is less than 7 millimeters of the solid component, then blood flow alone is not making this complex cyst for a malignant case. So you have to weigh your scale. More points towards this side is going more likely towards malignancy, but if it is getting diluted with number of criteria which are present in the benign, then you have to see where you are. Now for example, you are having a septation over here. Now see the septations. You have to see how many septations. Now I will not.
Okay. Multiple septations.
I will not tell you each and everything repeatedly. You have to see what.
This is actually a crisp thing.
Yeah, this is the crisp thing. You have to see 4 papillary structures. If there is 4 papillary structures and more, then it is going in favor of malignancy. Now this is the key, and here is the lock.
Yeah.
Now over here I am having a vasculature over here. Now see, I am having a vasculature over here. You know where to go. Now this is the solid component over here. This solid component, when I am measuring the solid component across,
7 millimeter,
and if it is 10, for example, 10 millimeters, then is it benign or malignant?
Mostly malignant.
Mostly malignant. Why? Because I know that the solid component should not be, should be less than 7 millimeters. So the point is that you should understand the theory first. This is the theory. Then only you can decode the pictures. If I will start from pictures, we will land nowhere. So this is the
interpretation
of whatever we have discussed over the top. So this was all, not all about. This was a sketch type. What you have to see in the ovary and how you have to correlate your theory with the pictures. Next time we'll be taking PCODs.